Without any delay, let's get started. I am Dr. M. Shreya Jaiswal, currently pursuing PhD in oral maxillofacial surgery, and I'm the host for today's session. Today, we have Dr. Nagaesh Dolare from India with us. He has completed his BDS from Government Dental College and Hospital Aurangabad, followed by MDS in periodontics and oral implantology from Government Dental College and Hospital Nagpur. He has academic experience as an assistant professor in GDCH, Nagpur, and 15 years experience in clinical periodontics and implantology. He is also the member of Indian Dental Association, Indian Society of Periodontology, and active life member of Indian Society of Oral Implantologists. Okay, as well as he is CDE accredited speaker of Maharashtra State Dental Council. Beside this, he has presented many scientific papers in state and national conferences, and also conducted several seminars and workshops in the field of periodontics and implantology.
So, good afternoon, everyone. And today's topic is basal implantology, a boon for the patients. Why this is topic is important for today's era? Because this is a fast and modern lifestyle. People don't have the time. So people want a coffee, they immediately get the coffee from the vending machine. People want to transfer the machine, they just scan the QR code, immediately they transfer the money. Similarly, in the dentistry, people want a treatment immediately. They don't have the times. And if the patient wants the teeth, and we are saying just wait for 4 months, for 6 months, patient will not most of the time agree with that. So I want to do that, but I don't have that much of the time. And that's why the basal implantology will be the game changer and more beneficial for the patient. Next. So what exactly it's a basal implantology? Means implants are the place into the basal bone of the jaw, because there are two type of the bone in our jaw, is a cancellous and another one is the cortical. This is the more resilient, very hard bone, and that helpful for the placement of the implant. But basal implants always engage and placed in the cortical bones, and here conventionally implant we placed into the soft bone or spongy bones. Next. So basal implant utilize the basal bone for the placement or engagement, and it will give immediate loading. Why? Because basal bone is very hard and resilient. As we load or place the implant, give the high torque, that is 60 plus newtons torque we get, we achieve, and we load and we deliver the prosthesis or teeth to the patients. So most of the cases, there is no need of additional any bone grafting, sinus lifting, or nerve repositioning. Additional surgical procedure is not required in this. And this is a, we can say it is a minimal invasive procedure. So patient will be more comfortable. As we engage the implant in the basal bone, so what happens? Immediately we give the teeth within 72 hours. Means treatment time also get reduced to the patients. And there is a good stability in the implant or torque. So immediately we give the prosthesis and patients start chewing after that. So this is the beauty of basal implant, or it's called strategic implant or corticobasal implant. Next. But most of the times, most of dentists think that, yeah, is it scientific? I can't provide the good aesthetics. This is another question in their mind. Sometimes they worried about the failure or what about the prognosis. I have seen many dentists, they don't put the single implant, basal implant, but they worried about the failure. But if you do the procedure, or sometimes they worried about the retriability, they don't know about the how to place the conventional implant also. But as you go in the detail of basal implantology, you will get all answers. And I'm trying to give the answer of these questions. Next. So, what is exactly science or concept of a basal implantology? So, in jaw bones, there is a cortical and cancellous bone. At the crest of the ridge, this is a primary cortical. Secondary cortical in maxilla is the maxillary inferior border of maxillary sinus, nasal floor. In mandible, this is a caudal bone, and posteriorly there is a below the insertion of myloid ridge. So these are the high density bones. Third, tertiary corticals, this is the pterygoid bone, zygoma. We use that bone for the placement of basal implants. Next. So here is, you can see in the first picture, that is a osseointegration versus osseofixation. So conventional implants work on the cancellous bone. That's why we have to wait for 4 to 6 months, and that implant get osseointegrated. But in the basal implantology, so implant get osseofixation. It means that we have to engage that implant secondary or tertiary cortical. So we will get the torque for the loading the implant. Next. So actually, this concept is come from orthopedic inspirations. It's just understand the concept. How is it? It is any bone fracture, like a femur or fibula. So they just give the plate, fix the plate to stabilize the fractured bone. Similarly, these fixation screws are like a basal implants. Plates act as a prosthesis as we deliver the tooth in a complete single arch form. And a fracture means whatever we do the osteotomy site. So this is the concept of basal implantology. We deliver the implant as well as the prosthesis. Next. So the history is a big history of this basal implantology since 1960 to 1970 from disc implants, and later on German dentists they developed the technology for the modern basal implanters. But in 1997, Dr. Stephen Ide introduced the lateral basal implant with rough searches. But again, they develop because that lateral basal implant is a little bit traumatic, lot of swelling. So it's very difficult to get the treatment for the patient. Patient was not comfortable. So that's why in magic it's happened in 2010. Dr. Stephen Ide introduced the crystal approach for basal implant. And that's why they consider as a father of modern corticobasal implantology. Next, what is a crestal approach and what is exactly basal implants? Basal implants are the one piece implants. It means that the abutment is connected with your implant body. So there are parts of basal implant. First, as you say, this is the abutment for the delivery of the prosthesis that receive the prosthesis. Second is the nape. It's a joining of the abutment and implant body. Body is like a thread, sharp thread around that implant, and tip is always smooth. Next, so immediate loading is possible because these implants are self-cutting, so that's why it contains the more bone, and we'll get a good implant bone contacts. So this is the best outcome for our prosthetics. Second one is a collar or a neck. So this is for aesthetics and for good functioning strength. But in the neck is a best for the building the implant. Conventional implant, it's a prosthetic driven implantology. But in basal implant says use the existing bone to deliver a prosthesis. Next, next, yeah, thank you. It's a most of the time it's a so progressively and wherever is a higher bone implants will get contact through the basal implants. They are self-penetrating and polished apical tip. Because when we engage this tip into the base of the or inferior border of sinus or base of the nasal floor, so that will not harm to the any lining or tissue. So this is a complete smooth surface or polished implant. Next. So, basal implant, these are the mostly common areas for anterior mandible in there is a caudal area, at least 10 to 12 millimeter in anterior regions. This is a very high density bones. Form the posterior of the mandibles from the lingual cortical plates. That is a cortical engagement just below the myloid ridge or on bilateral. In maxilla, so there is a nasal floor, inferior border of maxilla, pterygoid bone, and if there is a severe resorption of the bones, we engage the zygoma. Next. So this is a crustal approach. Single drill, we do the drilling at a single drill and put the implants so through the crest of the bone and engage the respective high density bone or basal bone. Next. So as you see on the screen, on the right side of there is a basal bone, but it's a golden color. There are a modification of this implant. Part of implant is the at crest, this is a smooth and at the apex also smooth, but in between the implant is a rough surface. It's a like a conventional implant. For the that implant get osseointegrated, but basal implants are ossifixation. But most of the time, we think that here this is a one-piece implant and it's very difficult to retrieve. In that implant system, in Quickdent's implant system, we have that much, that is options available for, that is a TPR implants. We can give a multi-unit abutment and restore in the same way within a 72 hours. Next, next. Yes, in this slide, we can see in the first right side, so there is an implant placement in different directions. But basal implants have the property we can bend. So my experience with the Quickdent is a very nice. They have a good bending ability of that implants. Easily they can bend. As you see in the last pictures, all implant abutment in a parallel fashion for the delivery of the prosthesis. Next, basal implants bend from the neck. The bending ability of this implant is it's minimum maximum we can say maximum 90-degree we can bend the implants. Means however you put the implants, you can bend that implant and that abutment will be in the arch form in parallel fashions. Next. So look at this in video. So all the features, anatomic collars, body, self-threading, tapping implants. In basal implantology, it's very important how much your implant gets bent. This is a beauty because it's ossification technology. Means once you engage the implant, your implant should be easily bendable. As you seen in this video, so see the direction of implant placement and after the bending of implants, after bending, all abutment will be in a parallel fashion. When you're doing the implant, it's the immediate extractions. Always you put the implant in subgingivally. So in future, if there is any recession, so there will be no gap between the prosthesis and soft tissue. So most of the time we put the implant in pterygoid region. So to achieve or engage the pterygoid bone, we have to give the angulation for the placement. After that, we can build the pterygoid implanters. So very good implant with a bending ability. So coming to the bending at manual. See, look at the direction of implant placement, and after the placing implants, all implant abutment will be in a parallel fashion. Before you do the impression, you have to do the bending. Before bending, you have to take the OPG, also confirm that your engagement with the corticals. These are the impression. These are analogs. These are the burnout caps for the processes. So lab guy can modify the burnout cap, make the wax pattern. Nowadays do the digital also. And as per the processes, we give the PFM, zirconia, the HIPC processes we can deliver to the patient. So this is a cosmetic or aesthetic result. Next, it is a repeating that. Next, yes. In this implant system, you can see some drivers are there, some drills are there. Most important is a hand grip. And if you want to place the implant, it's a pterygoid tab for the placement of pterygoid implant. Next, this is a very compact kit for the implant placement. There is no multiple drills. Hardly one small and long drill is required and hand grip is required. There is no need of multiple drill sequence and everything. So single drill, we have to do it and place the implant. Next, so let's see the some cases and see the aesthetic result and the follow-ups. So this is the 55-year-old patients come with some mobile pathological migration teeth. Some teeth are missing. So naturally that patient was in police departments. It's very the bad feeling for him whenever he talked to the patient. And but when he visited to me and say, I want to fix teeth, but I don't have the time. So we took the X-ray. Next, on OPG, you can see there are few teeth were present, and all are pathological migration. A lot of bone loss was there. See the maxillary sinus rheumatization and severe bone loss is there. Next, we did the CBCT is very important, but basically you should have the OPG to understand the where is the bone is there, how much is bone. But before do the implant, you should do the CBCT. So this is the implant placement in maxilla and mandible. Next, after the implant placement, you do the OPG and see the engagement. See that there is a multiple direction because I didn't perform the bending. Next, after bending, you put the impression post over that. Next, all impression post join with a pattern resin. When you take the impression, all your impression posts will be come out in a impression like this. You have to take the impression in maxilla and mandible. But if you do the extraction, immediate extraction in implant placement, don't use the light body, just use the putty impression. Nowadays we can do the scanners. After the impression, you have to take the bite. Next, and send to the lab. So lab will work on that and they provide you jig. Put all the jig into the patient mouth, trim all the implants and do the metal drying. After the metal drying, again you have to provide the bite. So bite is very important in this time. Next, and finally you will get a prosthesis and you can trial that, check the all aesthetic parameter with the patient. If the patient is agree and as per your aesthetic criteria everything is okay, then go for OPG first before the cementation and after that you cement the prosthesis. Next, so this is a post-op. Next, this is extraoral pre-op and post-op. You can appreciate the result, the looks of the patient extraorally as well as the intraoral. So this is the after cementation. So 1 year follow-up, you can see the OPG of this. Absolutely, there is no bone loss. Best part of this case, the case actually was a periodontitis. We put the implant immediately. Still, there is no chance of peri-implantitis because all implants are polished. I have never seen the peri-implantitis with the basal implant. Most of the time, we in conventional implantology, we see the periodontitis. Lot of cases of peri-implantitis also. Next. So this is another case with upper teeth were present because of improper crowns and all lower recurrent teeth were there. We extracted lower jaw teeth and put the basal implant. Upper we give the all crowns. Next. So this is a post-op cementation of the lower prosthesis. We have to replace. Whenever this type of case is there, is a bite loss is there, you treat the case as a whole. Not like that the upper teeth like crowns are is okay and you are giving a prosthesis. You will not give a good prosthesis. But I did in this case, I replaced all upper teeth with a crown and lower with complete prosthesis, implant prosthesis. Next. This is another case, 62-year patient. This is a patient, as you see, the appearance of the patient face, the lot of contraction and the old look is there. Next. So this is the OPG of the patient. As you see in the OPG, in mandible, you can see in posterior region there is a no bone. And it's very difficult in such cases, as you see in the CBCD also, in axial section, you can see it's a very height is very less, and how to put the implants. Most of the time we plan early positioning in a conventional implant, but in this case, I plan that case for buccal nerve bypass, both posteriorly bilaterally. Next. So as you see, the after implant placement, both two pterygoid in maxilla and the eight implant in the in between in the anterior region. In mandible, I have four implants, buccal mandibular nerve bypass performed. Anteriorly, there is a soft bones, so wide diameter of basal implant was placed in the third quadrant. In maxilla, generally in basal implantology, we place 10 to 12 implants. In mandible, 8 to 10. Next. So after the implant placement, bending, everything performs. So prosthesis is delivered. And you check the prosthesis on the OPG. OPG is very important in every step. Next. So you see the pre-op of the patient and post-op of the patient. You can appreciate the how the facial look of the patient and smile itself will give the express everything for us. So this is one of the important case for me. This patient was in 60 years and last 5 years the patient extracted all the teeth and the patient have the gag reflex. That dentist who extracted the teeth, he first fabricated the first denture. Patient didn't use that. Again, he made the second denture. Patient didn't use that denture because of gag reflex. After that, after 5 years, just imagine there is a complete edentulous of maxilla and mandible. There's a lot of bone resorption and mimetization of the sinus. So after 5 years, he visited to Orofit. Next. And you can see this is a no bone in the maxilla. It's very difficult. So if you go for conventional, we do the lot of surgery, sinus augmentation and everything. But we plan this case with a basal implant. And in basal implant in maxilla is very less bone, so we plan the zygomatic implant. Next. Two zygomatic implants were placed in maxilla, two pterygoid, and five anterior implants were placed. As lower in mandible, we placed the eight implants. Next, this is a OPG of 2-year follow-up. So there is a no bone loss patient actually swimming very well, but patient follow is very important. Every 6 monthly patient visit, we have to check the what is the overall hygiene of the patient, how patient is getting cleaning their teeth and everything. Next, and this is a pre-op and post-op. This is just after 72 hours smile of the patient. So patient even don't believe she is a she look like so young. So this is a actually basal implantology. Immediately we deliver the result. So 20th April in 23, she reported 1st May 2023, we put the implants and for 4th May we deliver the smile to the patients. Next. So most of the time, last question in dentist mind is, there is no success rate of basal implants. So friends, actually go through the literature. You find the 98 to 99% of success rate with the basal implantology. And you know the what is the success rate of conventional implantology. Whenever you put the implant in the sinus lifting cases, just see the what is the success rate. If you are placing conventional implant in diabetic patient, you check the success rate in that case also. So actually here in diabetic case also, there is a no nothing will harm or change the success rate of your basal implant also. So this is a corticobasal or basal implant also. Next, so actually, I conduct the workshop on this 3 days workshop, and in this you can understand what is exactly corticobasal implantology, what is a bone, how to engage the implant, what is a pterygoid, zygoma, nasal floor, how to take the jaw relation, what is a complete prosthetic option, what material we have to use in which condition, everything you will get in that. And most important is the maintenance also, how the your patient in your follow-up. Next. These courses will be in mentorship workshops, 6 month mentorship in even conventional as well as in basal implantology 6 month mentorship programs. If you are somebody is interested, you can contact on this number. Next. So this is all about basal implantology. Thank you so much for Nasik Dentist channel online and Quickdent implant system. Thank you so much. If you have any question, this is open to you. Thank you.
Thank you so much, Dr. Nagesh, for such an insightful webinar session. So I would like to request everyone, like if you have any questions or any queries, so you may put your questions in Q&A box. Okay, I think there are 3 questions, so let's check one by one. So coming to the first one, yeah, any video popular? Oh, okay. The first question is, sir, what would be your first choice of treatment plan if sufficient bone is available? Conventional implant or basal implants?
Yeah, I use a corticobasal implant. I have shown you if the sufficient bone is there. So in basal implantology, I said 3 type of implants. First is a complete smooth surface. Another one implant is at the collar, it's a smooth, and at the apex of the implant is a smooth. And third one is a TPR. So my first choice in the sufficient bone loss is TPR implants with a multi-unit, and I deliver the smile or prosthesis within 72 hours. Actually, that case I have not covered in this presentation.
Okay. Next question is from Dr. Mansi Davesh, sir. Sir, which system of basal implants do you suggest?
So I have used a 3 system, but I find the Quickdent is one of the best because bendability is very important when you are putting the implant. Sometimes there is a soft bone, even cortical bone is also their strength is less. In such cases, it's very difficult to bend. But the Quickdent implant have a fantastic bending ability as we can bend up to the 90 degree. So my personal experience good with the Quickdent.
Okay. Uh, Hello, Dr.
Yes,
Nagesh. Yeah, okay.
yeah.
The next question is from Nadeem Ahmed. Which one to learn first, conventional or basal?
Implant which I learned. So can you repeat the question? Hello.
Uh,
Can you repeat the question, please? Hello.
Hello.
Can you repeat the question, please?
Yes, the question is from Nadeem Ahmed. Which one to learn first, conventional or basal?
So my suggestion is, because I am practicing conventional implants since 2008 and the basal implants last 5 years. So actually both systems are the different. Both concepts are the different. And if you want to learn the implant and give the fast result or fast derivative smile to your patients, go for the corticobasal implants. This is not necessary कि पहले first you learn the conventional and then you do the corticobasal. It's not like that. You can start with the basal implant also.
Next question is welding good or not?
So actually, welding is the option is there, but don't provide the welding, because if you engage the implants, so you are giving the stabilization with your single unit prosthesis. So there is no need to give the welding. So most of the basal implantologists, as per their system, they recommend to go for the welding. But since 5 years, I have not welded single in a single case, I have didn't even well done. And still there are good results with good follow-ups.
Next question is from Pragati Sinha. Adverse effect of basal implant.
Adverse effect, adverse effect is actually what I can say for that. But the patient is implant is made up of titaniums. As such, there is no adverse effect on the health. It sometimes it's a rejection, it's a different case, but it's a worldwide ratio rejection of titanium is a 0.003%. So rejection or adverse effect not, but there are some complication will be there. So these are the manageable complications. So over a period of time, so there is a gap between the prosthesis and your tissue surface will be there. But what kind of prosthesis you are delivering to the patient, that's a matter a lot. Suppose you are delivering this HIPC, prosthesis. In that case, if the gap is there, you just do the composite, regular composite or pink composite. You can do that and manage the problems. Another problems will happen or disadvantages sometimes if you are not deliver the occlusion proper. So suppose in the mandible, occlusion is not delivering proper. So mandible, one implant will get detached from the prosthesis, but we don't realize also. And if it gets detached from that prosthesis, sometimes there is a pain also. In that case, we have to cut all prosthesis and again we have to give the new prosthesis. This is a little bit time consuming. But if you want to change this, you can use a two-piece corticobasal implants. This is another good option for that or overcome. Just I already told you TPR implants.
The next question is from Nadeem Ahmed. For single tooth replacement, you would prefer basal or conventional implant?
So I generally use in basal there is a I use the PPR or one piece implant like a, 5 millimeter soft collar and apical at the apex of the implant is a smooth. This that implant I can use rough surface implant, not a basal implant. Basal is completely smooth implant.
Next question is how to do buccal bypass technique.
So buccal bypass technique. So you have to check the CDCT carefully. So you have to find the where is your how much is the distance from mandibular canal to buccal cortical plate or mandibular canal to lingual cortical plate. So if at least 5 millimeter is the distance should be there from buccal cortical to the mandibular canal, and then you can put the implants. So actually You have your direction from lingual to buccal up to the base of the mandible. You have to reach the base of the mandible, engage the base of the mandible.
So next question is from Vinuta Sridhar. If there is a impacted and can't be removed, what will be implant placement position?
Try to bypass it.
Next question is from Dr. Harish Juneja. Sir, whom to contact for Quickdent implants and surgical kit?
Yeah, I think you go for the online. This is a good option.
Next question is from Sri Lakshmi Sahitya J. What are the chances of fracturing bone during bending implants?
If there is a cortical bone is high strength bone, hard bone, but sometimes because of some reason, because that cases bone is a weak. So that time your implant actually fracture that in a cortical bone, but just it is a below the your periosteums. You just splint it. Nothing is going to happen. It will going to heal automatically. But there is specific bending technique. You follow that.
Next and the last question. Okay, second last. Sir, when you do with flap and flapless, I mean he means or she means to us that
Yeah.
when you do the technique like flap or
Yes.
flapless.
If there is a weight is enough and you can do the single drilling easily, so flapless, go for the flapless. If there is a thin bone is there and your drill will slip from that point, in such cases, you just give the crustal incision, just reflect the crest of the bone and then do the drillings. So you will create less trauma to the patient and you just give the suture on third day, you can remove that suture also.
Okay. Next, and the last question is from Tathagat Singh. Various corticobasal systems are available in market and each claims to be good. What should be the criteria to select one?
So already in my presentation, I said if the basal implant you go on, first question you ask means what is the bendability of the implant? It's very important in that. And what kind of titanium grade they are using. Two things, as per my experience, is criteria is enough for that to select the basal implants. Second thing, for the we can ask for what are the approvals. This Quickdent implant is FDA approved. So you go for that also. Means you have FDA, you can ask for them and go for that. Every product, every implant system obviously claim it's a good implant. Nobody says that my product is not good. And people who are using the system, you ask also feedback. Most of the implant get fractured also. So you ask the people who are or dentists who are using the implants.
So
Yeah,
this was
ma'am.
all
Next.
Q&A session. It's all over. And okay, I can see there's one more question from Rahul Ahir Rao. Perforation of second cortex is good by lance or twist.
Obviously, lens is a good option. Most of the time, twist, twist we have to use when there is any doubt. Twist is not going to cut the bone. You just create the space. Twist drill is actually 2 mm, and most of the chance is that when you are drilling, there is chance of breakage of drill also. So lance is a best maximum cases we have to do with a lance drill only.
Okay, thank you, Dr. Nagesh, for joining with us and for talking about such an important topic that is basal implantology. So I think, a quick takeaway note can be like regarding the basal implantology, like, it's a minimally invasive approach and
Yeah.
immediate loading capability and high success rate. As you talked that it has 90 to
Yeah.
99% prognosis, yeah. So it has very
Yeah.
good prognosis. So it makes this all together makes it a transformative or best option for restoring oral function and improving quality of life of patients. So thank you again for joining with us, and thank you to all the attendees. I hope that this session was wonderful for you and very insightful for you. Thank you once again for like everyone. Have a safe night, and okay, thank you. Goodbye.